Today, I'm going to present my senior capstone thesis final defense title, Designing Alternate Care Sites for Preventing the Overload of Patients in Existing Healthcare Facilities Amid Pandemic Conditions. First, let me introduce my committee members. On my committee, I have Mary Golden, NCIDQ. She's an assistant professor at RIT. She is chair of the undergraduate interior design program in the committee of this capstone project. Another committee member, Jennifer Kenson, who is a principal in the interior design sector at Francis Kaufman Architects. Lastly, I have Douglas King. He's a vice president at Project Management Advisors. He's also a member of the FGI guidelines, writing a new national healthcare code for alternate care sites serving in an emergency role. I want to thank all my committee members. Support has been indispensable since last September when this project began. I wouldn't achieve any of these even if I haven't met them. So for the background, little bit of background on my research. In December 2019, coronavirus disease first identified in Wuhan, China. It spread worldwide. On March 8, 2020, first 17 COVID-19 patients reported in New York City. And due to New York City is a very dense and packed city, the cases of COVID-19 escalated very rapidly. From March to May 2020, there were about 10,000 new COVID-19 cases per day. Local healthcare were lack of preparedness for unexpected disasters. The hospitals in New York City, patients were in the hallway, on the gurney, and everywhere. The existing hospital needed extra more space to serve overwhelming number of COVID-19 patients. And so my question is, how can alternate care sites be designed effectively within existing infrastructure to serve affected individuals amid an emergency such as a pandemic or disaster? This project begins with literature review. I read a few recent articles and papers regarding alternate care sites. Alternate care sites is a facility that's temporarily converted for healthcare use during a public health emergency to reduce the burden on hospitals and establish medical facilities. When COVID-19 hit in New York City, tent structures were constructed in Central Park, Manhattan, New York. U.S. Navy hospital ships were arrived. Also, Chavez Convention Center, SUNY Stony Brook campus were converted into these facilities. And these photos are the examples of alternate care sites which were used when nature disasters such as earthquake, flood, hurricane happened in Haiti, New Orleans in US, Mozambique. There are 3 levels of considerations for building alternate care sites by CDC guidelines. First, non-acute care is for patients who have mild or moderate symptoms of COVID-19. Next, hospital care is mid-level care for COVID-19 patients who have moderate symptoms. Lastly, acute care is for COVID-19 patients who have severe symptoms such as trouble breathing, persistent pain, or pressure in the chest and inability to walk or stay awake. Acute patients need to be taken care of by staff very constantly. When dealing with alternate care sites, we need to consider site considerations, programmatic consideration, engineering system consideration, patient and support services. Now we're gonna see case studies of alternate care sites about recent COVID-19 crisis. The first one is the Wuchang Arc Temporary Hospital, which was built in Wuhan, Wuchang Hongshan Stadium in China. It was impressed for how quickly it was built, and it had a capacity of maximum 800 patients. This facility was for COVID-19 patients who have mild symptoms. As you see, they divided their floor into 3 zones so that staff can have efficient and safe traffic flow. And this is a photo of Wuchang Arc Temporary Hospital in Arena. The other case study is McCormick Place, which was built in Chicago. McCormick Place, which is the largest convention center in the United States, turned into alternate care site for COVID-19 patients. Hall C has 500 beds in open cubicles for non-acute patients, and Hall A is for non-acute patients and have 50 beds in open cubicles. And Hall B is for occupation and have 750 isolation pods, including 15 critical care patients. Alternate care sites in Stony Brook campus were built in tent structures. These were for non-COVID patients and it had over 1,000 beds. Unfortunately, these facilities didn't take care of any patients during COVID-19 peak. It's because the cases of COVID-19 in Stockholm County didn't reach the number as expected. And next, this is a lesson learned from the past pandemic before COVID-19. When H5N1 influenza happened in Taiwan in 2005, CDC in Taiwan chose to convert schools into alternate care sites because schools are available. Students are learning remotely to prevent spreading the virus, and schools are distributed evenly throughout each city. Because of the structures of schools, our risk zone can be separated. Also, even though every school have all different layouts, alternate care sites can be adapted into each school. For my research study, I created one-on-one interview questions in 4 categories depending on demographics. First group is the healthcare workers who have experience working in New York City during the peak of COVID-19. This group can be split into 3 depending on their roles. And second group is environmental department workers who worked at the hospitals in New York City during the peak of COVID-19. And third is designers, architects, the essential workers from CDC, FEMA who participated in designing alternate care sites in New York City during the peak of COVID-19. And the last group is the patients who were sick from COVID-19 and suggested to go to alternate care sites in New York City. The interview was conducted through a virtual meeting, conference platforms, and phone calls. I was only able to talk to the first group, which is the healthcare workers, because of time constraints of this project. Healthcare workers that I interviewed were doctors, and they were working at the emergency department and surgical intensive care units during the peak of COVID-19 in New York City. During the interviews, they shared their experience with the peak of COVID-19, what they needed importantly in the facilities during the pandemic, how they think alternate care sites should be designed to take care of high acuity patients, and respite areas for healthcare workers. For findings, doctors addressed some issues that they had during the peak of COVID-19. There were lack of space in the existing healthcare facilities, so they utilized lobby and hallway to take care of patients. There were lack of personal protective equipment. The doctors found COVID-19 patients have lots of side effects, which are hypercoagulation, blood clot, stroke, and the others. Also, most of COVID-19 patients who have the other diseases originally are hard to survive. Lessons that I found through the interviews are COVID-19 patients are needed to be monitored constantly by healthcare workers. They need to have enough personal protective equipment for healthcare workers. And doctors think treating ICU patients in alternate care sites would be a very difficult challenge. To treat acute COVID-19 patients in alternate care sites, design has to follow the standards of emergency department and ICU in hospitals. Alternate care sites need to be designed as a mobile hospital, which has a laboratory to test blood gases, CVC, electrolytes, and dialysis machine, and X-ray machine. It needs to be prepared to perform tracheotomy yourself. For the preparedness of next pandemic or potential wave of COVID-19, preparing suitable equipment and enough personal protective equipment is very important. Hospitals in New York City increase space for COVID-19 patients, also to build alternate care sites for COVID-19 patients. Laboratory trained medical teams, pharmacy need to be prepared. If not possible, transportation to existing hospitals is crucially required. Moving on to the creative agenda, these are the solutions for solving the problems that I proposed. The design of alternate care sites that I proposed is inspired by Instant City. Instant City is a conceptual work which was drawn by architect group Archigram. Basic idea of Instant City is creating infrastructure in advance, and it can be used when the event happens in a community. After the event, infrastructure go back to dormancy. Alternate care site that I propose is converting high school to become healthcare very quickly. This project is not doing any big scale of alternate care sites, but smaller scale, and it's more prevalent across the country. For solution, the module system, which was created by US Army Corps of Engineers for acute COVID-19 patients, was a reference. A prototypical environment for alternate care sites I propose will be installed in typical high school gymnasium in the United States. High school can be first responder to any disaster because they are in each community, even though a scale of alternate care sites could be smaller than a convention center. Also, when the pandemic happens, schools are going to be empty since the students are going to learn remotely. Lastly, high schools have standards of space programming and dimension. alternate care sites can be easily adapted into each school. This map shows how the U.S. school district distributed throughout the whole nation. Also show alternate care sites in high school can be very uniformly distributed in town and community throughout the state to support each community. In spatial programming, there are 5 major spaces. We have patient area, staff area, patient support area, and clean material room, soil material room. For the time constraints of this presentation, I'm going to introduce only the major space. In patient zone, there are patient wards, and in staff zone, lockers, toilets, lounges, nurse stations, hand washing stations everywhere. And in patient support zone, medical tools such as dialysis machine, mobile x-rays, stat lab are included. Clean material zones and soil materials are have each utility and separate entry and exit for infection control. And the below soil material zones are site-related spaces. This is the traffic flow chart of each department that I propose for alternate care sites. This exercise allowed me to understand the relationship between rooms. There are 5 different traffic flows in alternate care sites, and I tried not to cross each other's department's flows for infection control. Fifth flow is the emergency access of patients, and it will show up on the site plan, not on this diagram. This diagram illustrates what the phases of disaster is. Every disaster has 4 components: response to disaster and recovery from disasters, mitigation, advanced planning such as prevention to the next disaster. This applies to all forms of disaster. So according to the disaster response phases, I created implementation phases for alternate care sites on typical high school layout. Phase 1 is going to be initial response to pandemic and disasters. And phase 2, patients are going to recover from disaster. And phase 3, it'll be prevention. These implementation phases are going to adapt into any types of threats to the community, including nature disaster, man-made, and the pandemic. By implementing the alternate care sites on typical high school, we can provide the equitable access to healthcare in the community that anyone can walk into the facility in the emergency situation. Now we're going to see 2 different scenarios for alternate care sites that I proposed. For the natural disaster case, this is a scenario of tornadoes and typical high school tornadoes. I'm picking up typical high school to emergency facilities. We are providing residents to be triaged and get temporary housing in the first phase. And in phase 2, there's going to be medical treatment and to respond to your existing healthcare facilities malfunction. And this is the phase 3, social support and insurance assistance are going to be provided to residents for their living. This is about helping residents' lives. And now we're going to place this into the pandemic scenario. Phase 1 is going to be the testing phase for the pandemic situation, and triage and testing for pandemic is going to be installed in the middle school gymnasium. If phase 2 is not happening simultaneously, patients are going to go back home and wait for their test results. This is the external connectivity to support the internal impact. We work to not cross the traffic to address the infection control. And this is a detailed floor plan for phase 1 of pandemic. So people are going to enter through the middle school entrance and wait for their turn here and do the paperwork, get tested, and exit through the other doors. This is a way to propose the wayfinding in the waiting area. And image of showing documentation area with wayfinding. And there are a couple of showing images to get tested. Another image of standalone testing. You can see how staff is going to be separated from potential cross contamination. In phase 2, patient wards are going to be installed in high school gymnasiums. Patients can walk into the facility and get triaged and hospitalized. Patients also can wait for their result in the site. If they're positive for virus, they're going to walk down this corridor and get hospitalized. This is the external connectivity to support the internal impact for phase 2. And you can see 50 isolation pods for pandemic patients and 6 nurse stations in this detailed floor plan. There are the images of showing isolation pods and nurse stations. And you can see the rack system here over isolation pods. And services and electrical systems are going to be installed overhead on these rack systems. Phase 3 is aftermath dealing with vaccines. Vaccine area is going to be installed in cafeteria, and post-vaccine is going to be in the media center. For COVID-19 case, patients need to wait for their reaction after they get vaccinated. So patients are going to stay about 15 minutes in post-vaccine area, depends on the virus type. Post-vaccine area can be used or not. And this is the external connectivity for phase 3 of the pandemic. I have 72 cubicles for vaccine area. And there's this the image of wayfinding and signage is in the vaccine area. Next, lastly, phase 4 is not an architecture phase, and it is an operational phase, which is engaging community resilience to form operational team. This was a reference from a model of McCormick Place. There are going to be 4 categories of organization. First, leadership group, and 2 facilities, 3 clinical group, and 4 logistics. I appreciate your time for joining this presentation today. Thank you very much. And now I'll open the floor to questions and comments.
Thank you, Minerva. So we'll open the floor first to Dr. Tai.
Thank you, Minerva. Fantastic job in putting together this very important and timely study. I'm very impressed by the rigor of the study for undergrad thesis project. Very thorough in terms of collecting the relevant evidence regarding alternative care sites, and you really showed thorough process of evaluating the best practice case studies for this particular building type, and also the decision to select high school as a potential prototype for future alternative care site is very smart because it's a readily available community resource, and it has a wide applicability in the nation for not only dense urban area, but also for remote rural area where there's limited resource such as stadium and other convention center available, but they do have high school. Every rural community has their own high school, and that become a amenity that they could turn into a very important alternative care site that can serve the local community and reduce the travel and transportation of patients and reduce the risk of the spread of the disease throughout the process. So again, I'm very pleased to see this study coming together, and good job. I have a couple of questions and comments or suggestions. So can you please go to your traffic flow chart that shows the adjacency and the movement?
This one?
Yeah. So first of all, I think you did a good job in terms of separating the patient traffic flow, the staff and clean and soil supply, which is really important in healthcare design, and did a good job there. However, I think in terms of the traffic flow chart, you might want to create 2 different scenarios. One for the tornado or natural disaster versus, pandemic or infectious disease related traffic flow, because they do have quite a difference in terms of how you control the one-way circulation for the infectious disease related situation. So that might have a different impact in terms of how the adjacency of the space would work. And then the other small kind of suggestions, right now you have kind of a centralized soiled supply storage and clean supply storage off the side of the patient wards. And within the patient wards, you typically want to have the cling and soil supply as well, either right adjacent or connected to it. And your physician, a nurse, especially the nurse station, need to have direct access to the cling and soil. So that's just something that you might need to consider in terms of how visually you describe that flow and that critical adjacency.
Yep, thank you.
So the other suggestion is, I think you have done a great job in your case studies. I wonder if you have also looked into some research on biocontainment unit, and then the related kind of design principle that they have point out regarding design specifically to address infectious disease. Have you came across any kind of research on that topic?
Oh, no, I haven't yet, like on that topic.
Okay. Okay. Yeah, that's perfectly fine. I mean, you did a great job in the literature review and case study. It's just something additional that might be helpful for you is to look into the biocontainment unit there are two cases that might be helpful. One is in Nebraska, Lincoln University biocontainment unit, and the other one is in Emory University. And there was actually a series of articles and research published by a group of scholars from Georgia Tech that have basically summarized the key design characteristics that can support safe delivery of care to protect, healthcare professionals during those scenario. So you might want to look into that, especially in terms of the unilateral movement and the dedicated donning and doffing area, which I see that you already had that kind of indicated in your traffic flow. It's just a kind of a matter of making sure you also touch upon those important literature. So in terms of the interview questions, can you elaborate on what you learned from the interview process? And if you were able to continue this research in future, what would you do differently in terms of your interview?
So since I wasn't able to do lots of interviews, hopefully I'll have more participants to have more opinions on like alternate care sites, and also sorry. What I learned from interview was it's like little different from like what I see in the media and opinions from doctors. And I think I found lots of errors from the interviews. And I think conducting more interviews are gonna be like find more errors in about what they really need in alternate care sites. So I think I'm gonna focus on what really like healthcare workers really need in like alternate care sites.
What is the biggest surprise for you during the interview that was kind of different from what you have expected or read from the social media?
So social media, they were focusing on the budget of alternate care sites, even though they spent lots of money on this alternate care site. It was like waste of money. They were focusing on those, but like doctors were saying there were troubles in sending the patients to alternate care sites, and they didn't really want to send a patient to alternate care sites because they wanted to see patients like directly. They said they know how to like take care of patients. And I don't believe alternate care sites to send them. So I think if I do more interviews, I think I'm gonna find this like solutions for those problems, I think.
Yeah, those are great points. And I love the fact you design your interview to be kind of covering multiple perspectives. You're not just looking at, healthcare workers, you're not just looking at patients, but you covered a wide diverse population or end users that will be involved in this particular building type. So great job there. And I looked through your appendix of your interview questions, very nicely put together, and covered a lot of good points that we need to consider as a designer. And it's interesting that you kind of mentioned the fact a lot of alternative care sites were built or constructed without being used. That's a waste of resource. So I think you can perhaps further elaborate on the value of your design that way, by saying how much space you have saved without being overbuilt, over construct, and the way that you can leverage the community engagement and community participation in the process, and also build the trust with healthcare providers as well as the community members. I think there in your conclusion piece, I would say you could further elaborate that in the manuscript. And the other thing I would like to really comment you is the nice way of dividing the response by phases, the initial response versus recovery versus the prevention. These are quite different in terms of the type of activities that we need to provide and offer space for, and also the different flow. So the way you design the space really demonstrate your understanding of the process as well as activity that would happen in each phase. A small suggestion is for the testing, which is your phase 1. If you go to that particular drawing, yeah. This one right here. So I wonder, do you have a separate weighting for people with symptom versus no symptom?
Yeah. No, I only have like waiting area for get testing, like before testing and after testing.
Yeah, so that's something you might want to consider, because when people come in for the testing, some might already have symptom and some might not, and you might want to create separate waiting zones to prevent to do better infection control that way, right? Prevent the risk of disseminating that disease during that testing process. And also I see phase 1, the other thing is for people who have been tested positive, whether it's wise to send them home, or whether it's, depending on their symptom and diagnostic, it might be helpful to have an observation unit available in your high school alternative care site. So whether they are held temporarily there before they got sent to the local hospital, or they could be there, just temporarily for observation purpose. So that's something that you might want to consider as well. And then the phase 3 is the prevention piece, is when you do the vaccination, which is great. And I think the flow makes a lot of sense to me. Again, the only thing is for phase 3, as we know, this pandemic is long lasting. And, as we reach phase 3, the school might be open. Students will come back for hybrid learning, perhaps. So you might want to think about if there's any way to still allow that vaccine to happen, utilizing the cafeteria or the gym space, but being able to separate part of the building so that the learning can still happen partially in this building, just to kind of make sure that learning can be conducted simultaneously while the vaccine process is happening. So it's a small suggestion here.
Thank you.
But other than that, I think it's a really well done research and design project. And I see a lot of potential in future application of your prototype. In fact, I do a lot of research in rural hospitals, critical access hospital. As you know, for remote rural communities, the two main buildings they have, one's the hospital and the other is the high school. So this really have value to provide on-site care for those remote, underserved rural communities. So I appreciate your contribution to this topic, and make sure you highlight that in your manuscript. Yeah.
All right. Thank you very much.
Thank you, Dr. Tide. Doug and Jen, if you'd like to offer your comments and your questions.
Jen, would like to go first?
Go ahead, Doug. Go first.
Okay, sure. Well, I was fascinated with this project. In fact, Minerva reached out to me via LinkedIn. That's how we got connected. She had read some articles and just blindly reached out, and I'm so glad she did, because I have learned a lot since maybe it was September that you reached out. You know, as you know, I was active, as you were, on the FGI guidelines committee. And so I was watching her project take form as we were working on the committees. And I was on the alternative care committee as one of the leaders of that committee. And so what was interesting was Minerva's ability to absorb new information into her thesis. I remember the day a couple months ago when I landed the 700-page draft document on her inbox, you know, and I was hoping she didn't have a heart attack when that came through, because it's a lot of information, and she, to her credit, has went through that and been able to absorb and actually comment on, you know, things that were in there. And I was really moved actually by her enthusiasm on this project and the hopefulness that it offers. So what I found working with Minerva on this on a regular basis, I would say, is that she is very good at handling programmatic and flow related issues. She's very logical, and came upon the idea of treating this not only as a micro, you know, spatial exercise within the high school, but also dealing with the macro element of the site itself. A fact is frequently forgotten on these kind of projects. These kind of projects, people forget that there's a whole element of the site itself. And so I appreciated the opportunity through her and through Mary, Professor Golden, to be part of this exercise. I think it's a fantastic program, and I think it was a fantastic experience for me as an individual to witness it. And I really don't have a lot of comments for Minerva. I've made my comments in the past, except that she did a great job, and I think she did a great job with the interview, or not the interview, but the presentation. I know that's an area that she's worked very hard at in the last several months. So thank you.
Thanks, Doug.
Minerva, great job. I know we've talked every time we've had a review, we've talked about your presentation. So I think come a long way from that really fast talking one that you did day one to now. It was great. I also appreciate how timely your presentation is. And, you know, Doug and I are working day to day with our clients, and we throw at you, I knew I did every time I learned something from my client and I meet with you every week, I would add another kind of layer of something and challenge you to address. And you always did. And you came back the next week with a solution that worked, or we tweaked it. So I appreciate that. The landscape is changing for us professionally. We talk to physicians, you know, weekly in our presentations, and we've conducted interviews ourselves, and they're reiterating some of the problems that you came up with in your interview. So it's great to have somebody kind of to talk with things that we're dealing with on a professional level. So it was an interesting project for me to be a part of, and I think you did such a great job. I'm not going to add a lot of questions because we talk weekly, so I know so much about your project. I think the one thing that might be interesting to, if you had another couple months to work on this, might be to really try to get interviews with the COVID patients, because to really how they experience these spaces would be interesting to see how you could improve their experience. And even the staff make suggestions on how they could, whether it's aesthetics or operational or functional or technology or whatever that might be, but it would be a good, like another layer to add on to your thesis would be great to learn that if you had the time. But I think for me, that was just like the one missing piece. But I know you were limited. Especially I know when you were doing your interviews was like early on pandemic and nobody had time for this. Like they were so focused on doing their job. So I think now, physicians, we're finding, I am, that they have more time and they do want to tell us, they do want to get the word out on what they dealt with and how we can make things better. They're very open and receptive to talking about their experiences. So that would be something to learn from if you want to augment your manuscript at the end.
Yeah,
But great job.
Thank you. Thanks, Jen.
Jen, I just want to echo with you about the patient perspective. I think it's so important to understand the impact of the alternative care environment on patient during those very difficult and stressful time. So I think interview is one way of gathering data. Minerva, since you are much younger than us, you're probably more social media savvy. Maybe, I have seen some interesting research that actually using big data through social media and capturing the users' feedback, patient feedback on those environment. And that might be an alternative way of gathering additional user experience through those open platform. Yeah.
Okay, thank you.
These are fantastic suggestions. Thank you. These are fantastic suggestions and comment. I think we've been able to have such a high level discussion because of the quality of the overall project. So Minerva, congratulations on completing a very successful capstone. So thank you very much. Okay, and so now I would like to extend a sincere thank you on behalf of RIT's Interior Design Program to Dr. Tai and to our committee members, Jennifer and Doug, for their valuable feedback. We're deeply indebted to all of you for your thoughtful cross-examination of our student work. And I would like to also thank our moderator, William, for helping us out behind the scenes. And of course, to our audience members, both here in person, yay, and on the call for your attention and support of Minerva's project. The committee and examining scholar will now enter the breakout room for deliberations. And this completes the final oral defense for Minerva Jang. You are all welcome to congratulate her following the presentation. She is our final capstone presentation for our inaugural event. And so I want to also extend a sincere congratulations to all of our students and wish everyone well, both in graduation and in their future careers. So congratulations. And everyone have a wonderful day and great summer.